ATFL for the ankle, the amount I'll use usually 1.5 milliliters for an ATFL. I want to make sure I'm using about 2.5 billion platelets. So here's what.
So again, the way you find the ATFL is you put your fibula in the center, rock your distal end of the probe flat. Your probe has to now be parallel with the bottom of the foot. Once it's parallel with the bottom of the foot, the ATFL pops out. So here's a little bit in the skin and down to the needle track. Now it's a 30 gauge 1-inch needle, so it's kind of hard to see. Then put the needle on my.
So again, you're seeing in all these videos, I'm using a small amount of dilute anesthetic to make sure I can get to the right target, get a needle, get some practice with it, and also confirm with the patient, yes, that's their painful spot before I put PRP in there.
For the ATFL, you doing okay? Okay.
So here's fibula up top. I'm doing all the places where the ATFL attaches.
So usually about half a milliliter or a milliliter at each entasis. Come a little more distally.
So selecting the right patient. So why did I do this for this patient? This is a woman who had had an inversion sprain. She'd had I think it was like a posterior talar fracture. It was a really weird injury. And a year and a half later, she was still having ankle pains. We tried low dose cortisone and it helped for a month. And then we moved on to the PRP. We had to do it 2 or 3 times and she got improvement, but then she'd come back and we do low dose cortisone again. So I have been to so many courses where people say, look, this treatment will work 90% of the time, or they'll say, learn this technique and it'll work 95% of the time. I'm here to be honest with you and say, if you select your patients right, I think PRP can be very, very helpful in 2/3 of the cases, but I do not abandon all the other treatments. I do not abandon physio. I do not abandon cortisone. I do not think it's 1 or 2 injections and done for the rest of their life.